thank you for being interested in this session about health creating commissioning. So what is health creating commissioning? I'm not sure we actually have that answer, but we've coined the phrase and we're going to explore that together in this session. See if we can put some meat into a title. But if we are serious about investing in community agency, then we also need to be serious about developing the mechanisms to do that and to hardwiring them. I've heard quite a bit about hardwiring today. We haven't hardwired in the past, we need to hardwire today. So how can we develop mechanisms for investing in community agency as a matter of course? So I'm delighted we've got two speakers who are going to explore this with us. And in our response to the 10-year plan, the Health Creation Alliance proposed the devolution of resources through what we called neighbourhood commissioning to make it a bit different from that strategic commissioning thing that is being talked about in the 10-year plan. We said there needs to be a neighbourhood level of this to create a dynamic neighbourhood ecosystem of grassroots and social determinants, plurality of provision. And that term plurality of provision is one that's being used in the 10-year plan. So we thought, why not use it to describe the ecosystem at the grassroots level that we need to emerge. So what we're trying to do is develop an ecosystem of formal and informal activities, services, whatever it is, shaped around what communities want. So in this session, I'm wanting to see if we've got this right and if we could improve on this as a narrative and what it might look like in practice. So this is a real research session, really. So, and we've got three brilliant contributors, and I'm going to try and keep them to time, so about 10 minutes. The first person I want to introduce is Dr. Mina Gupta, so Clinical Chair of Modality Partnership. So Mina, I know you've been doing some great work in this respect, so we'd love to hear about it.
Thank you, Merron, and thank you for the invitation to come and showcase what we've been doing. So as Merron has said, I'm Dr. Mina. I'm Group Clinical Chair for Modality Partnership. We're an at-scale provider, very much based in NHS care, working with an NHS ethos, and we have got now significant expertise whilst running 53 sites in social values and health creating. It's a new term, health creating commissioning, but actually when I thought about what Merron had titled this session, I thought that is exactly what we do. So we do a lot of work in lifestyles medicine, in population health, and obviously in service delivery. Our reach now extends to a core population. We provide primary care services for 450,000 patients. We're obviously involved in a number of different PCNs. And our adjacencies, we run a community outpatient set of clinics, providing care closer to home to patients. And we're now touching in the region of 12 million patients overall. So we've got quite a good spread across the country. The challenges that we faced are really quite significant. As everybody knows, primary care is really busy. And some of that, I would say, is our own creation. So we generate our own work inappropriately, but a lot of it is due to the fact that, particularly since COVID, we've seen huge numbers of increased morbidity, particularly with mental health. So people in health systems just say, oh my goodness, I'm too busy to do anything. We need more time. And the usual thing about we need more money. Wondering about how we can then create the resources to be able to do what we want to do. And generally, our services are delivered now to serve our staff rather than our patients. I mean, it's a horrible admission to make, but actually I do think that's a lot of what I see. That, you know, we've got contracts with people, they need to leave at 4 o'clock, and so the service is designed around that rather than us saying to the patients, what do you need? And then employing the staff to deliver to that agenda. So the other thing that we've discovered in our journey is that small pilots don't really work, because you have a small pilot, you deliver that pilot, but actually then extending that pilot into other areas everybody just expects the money to come first. And therefore, the pilot then doesn't spread, and it doesn't enable other people to join and to carry on doing what we've shown can be done. So just to give you a brief overview of, why have we decided to change the way we deliver our services? Well, of course, there's the economic reason, isn't there? We recognise that health doesn't sit in its own environment. It sits in the environment of housing, jobs, inequalities, culture. There is so much more to health that we need to engage with in order to keep our patients safe. And trying to keep patients at the heart of what we do is paramount. As I've already said, we design our services around ourselves rather than our patients. With everything that's going on and the way the health service is changing, health literacy and enabling patients to use digital technologies is absolutely at the heart of what we're trying to do. And Lord Adebowale talked about data. So we use data really well to see where we have gaps, and I'll show you some examples of that in a little bit later. And also the fact that this data has got to be usable. Now, within our communities, the people around us, we have to find the right partners. We have to find those willing partners who want to work with us, who share our vision of improving the healthcare of our community. But we also need to have parity of engagement. So we can't have the doctor sitting there going, "Hi guys, I'm the doctor, I know what to do." We need to listen and hear and redesign based on everybody's views. Estates is also a big issue that we've had to consider. Our own premises are often very busy, very full. We don't have the space for sort of community meetings. But there are local amenities that we can take free of charge. There's also work we can do with community partners to use their premises. And then funding is another big thing, but I'll come back to funding. And Merron made a very challenging comment about how I hadn't put anything about funding on there, but I will come back to that. The one thing that we found that has really been fundamental to what we've done is that our staff really enjoy this part of their community work. This gives them a huge amount of satisfaction, job satisfaction in what they do, and in terms of their well-being, they really enjoy this type of program. We've also discovered that the leadership, everybody's talked a lot about leadership from what I've heard this afternoon. The leadership part of this is vitally important. Having patient safety at the heart of what we do and having all of the systems and processes that we put in place with GDPR and patient safety has got to be at the heart of everything. So I'm just going to briefly take you through, I'm worried about time here, briefly take you through a couple of the things that we have done, particularly in our Bradford communities. And the reason that we've done this in our Bradford communities is, Bill, stand up. When we talk about relationships, this man, Bill Graham, he is our relationship lead. He can get into any community arena and find a role for primary care and stick his hand in the ring and say, yeah, we can help, we can do this. And that goes back to what Merron was saying about money, that we don't have any money in primary care to put towards these services. What we have to find are willing partners to work with us to redesign services around patients and to repurpose money coming into the system. And Bill is the best at finding this type of money. So obviously, Core 20+5 has been a big focus of everyone's attention, and cancer screening is something that has been obviously at the heart of one of the programs. This project has actually put together a whole set of a whole set of videos related to cancer screening in many different languages. And we know that language is a big part of our issues within primary care. I try to employ staff from my local community, which means that we will have a spread of languages. But actually then, medical language is quite different, so we can't expect people to translate all the time for us. So these videos that people have put together have been very well received. The other thing that's been happening in our communities is the immunisation rates across the board, particularly since COVID, have been falling massively. And again, this is where we use data to identify where we have started to see that drop and what we can do to address it. So you can see on the slide, the very left-hand side, right-hand side at the end anyway, it tells you how much we've improved the vaccination rates in the area. And this is by going out to the community, going out to local centres, shopping centres, wherever, and saying, hey guys, we're here, we're happy to vaccinate you, let us do it. Talking to parents and reassuring them about the safety of the vaccinations in a setting where they feel comfortable with the community they know and understand around them. We've done targeted events, again, for serious mental illness and learning disabilities. So we know that learning disabilities, again, using our data, we don't do very well with learning disabilities health checks. We know that, on average, the life expectancy of a person with learning disabilities is about 10 years lower than if you don't have learning disabilities. So we really need to ensure that these patients get the best preventative care possible. And we continue, Bill continues with his work, doing what he now calls high street health. So trying to deliver preventative care in the high street. And those are just some of the things that they will cover when they go out. I mentioned before about digital. So digital technologies, if you're not used to digital technologies, they're really hard to use. So if we're expecting people to move to that form of communication with us, we really need to help people understand how to do it. You know, it's great to say, oh, you can get your friend to help you or you can get your relative to help you. Well, I'm so independent, I wouldn't want my children or my friends helping me. I'd want to do it myself. So this is a great way of helping people learn how to interact with the new forms of services that are coming. But it also doesn't mean that that's the only way of interacting. The more people we can train up to use digital health technologies, the less people are cramming up our phones, and we then have more time for those vulnerable patients who then can't use the digital technologies. Mental health transformations. So this was very much a project that Bill worked on, where he connected all of the local community resources and put them all together, working together in partnership for mental health. So this was very much about repurposing money that is already in the system to be more inclusive, and so that primary care can get involved with all of the community health partners. This is one that they love doing, the park run. Oh, 1 minute. Oh, my goodness, right. So just wanted to quickly say how this aligns with the NHS 10-year plan. And obviously, we've got our hospital to community, and that doesn't mean primary care to me. To me, that means neighbourhood health, and I know that Minal has been here to talk about that. The analogue to digital, we've talked about a little bit already, but the most important thing is this sickness to prevention, and really that is the only way we are going to sustain our NHS going forward. Lots of things that we've learnt. We've learnt about how we need to make the effort, imagine what we'd like to do, how we can redesign. We talked about resources, and we've talked about how we started off. And again, I'll just come back to relationships, because relationship building is the most important thing that we've learned. Bill is a trusted partner in his local community, and people will come to him to say, how can we work together? He doesn't really have to go to them anymore. That relationship building has been the best thing. There you go. Whistle stop talk. Fantastic.
Thank you, Mina. And yeah, that deserves a round of applause, doesn't it? I mean, I was just so impressed that you seem to have pulled off the trick of redeploying the finances, so reshaping the services as you're repurposing the money to reshape the services, and a sort of virtual loop, which many could learn from that. So we'll come back to that and a bit more about how you've managed to do that. So, so the next speaker is Rebecca Hunt. I think you've got two names. Is it Brooker Hunt? Yes.
I used to be Brooker, now I'm Hunt.
Okay, Rebecca Hunt then, Director of the Social Value Collective, and we're going to hear about social value. I'm looking forward to this one. Thank you.
Absolutely. Yeah, good to see you all. Oh goodness, got to hold on to that. Good to see you all. Yeah, I'm Rebecca. I've been working for about 15 years in the public sector, doing kind of community development and health creation, but I now run, as Merron said, the Social Value Collective, which really aims to think differently about how we generate the resources to support some of this health creation kind of approach. So today, the slides, I have to do that myself. There we go. So today we're going to be thinking about how we can turn social value policy into an opportunity that actually benefits our residents. And I'm going to run it as a bit of a micro workshop. So hopefully you'll be up for that at this point of the day. So we'll be covering kind of what do we think neighbourhood commissioning is, why neighbourhoods, how can we resource it, and hopefully you'll leave here with a practical thing you can take away and start doing from tomorrow when you return to the office. So, I mean, firstly, thinking about what do we actually mean by neighbourhood commissioning. So, to me, and how I'm referring to it when I talk about it, is this shift in power and resources down to a local level so that the services we are designing are actually shaped by the communities they are there to support. And this is about commissioning in its broadest sense. I'm not just talking about a kind of formalised process, but that idea of mobilising support at a community level, whether or not it's paid for by the state. So that means that it's shaped by communities, and most importantly there you can see it's asset-based, which for me in the work I do is an important part. So we all know some reasons why neighbourhood kind of commissioning is the right thing to do. We agree with it, we've read the 10-year plan, we get it, it's something we need. I've put some of those possible good reasons there. No doubt you've got your own. But for me, the question behind all of this is how on earth are we actually going to resource it? And when there's pressure, like we face now with restructure and finances and demand and all these things going on, risk appetite is low and capacity is already really stretched. So in that environment, how can we possibly make the idea of neighbourhood commissioning something we can actually achieve? So the question I've got for us today is how can we resource neighbourhood commissioning and this approach with minimal risk and absolutely maximum impact? And for me, the answer is using social value. So thinking about what that is, the Social Value Act, it's a piece of legislation, actually came into force in 2013. So it's been around a long time, this is not new. And what it requires is that anybody who's commissioning services using public money should secure additional benefits. That could be social, economic or environmental benefits for their communities. And those benefits, often they support things like net zero or they support economic development. But the untapped potential for us here is how those benefits could actually support health creation. So the Act actually becomes a tool for us to think about those providers that we've got working alongside local authorities, alongside NHS bodies, as a strategic opportunity there to partner with them and actually involve them in our place-based approaches. So those providers become part of us shaping what's available in our local communities. And the Social Value Act legislation from the government says that social value should account for 10% of any public sector contract. So it's scored as part of evaluating those tenders up to 10% of the score. So it really is in those providers' interests to offer that social value and to do so in a way that meets what you want to happen, because it helps their chance of actually winning those contracts and getting their business. So this is something providers want to do. The legislation's already there. And the best bit about it for me is that you get to define what social value is. So you get to say, this is the social value I'm looking for in these contracts, this is what we need, and providers, as I said, are willing to respond to that because it's in their interest. So if we start to think about what that looks like then, because this has been around since 2013, all the processes are already in place to do this. In every public sector contract that's already going out, they are already asking for social value and evaluating it. Everything is, the capacity to do it is there, everything is in place. The only bit we haven't done, the unticked box there, is actually describe what it is our neighbourhoods need. So there is an opportunity here to describe those neighbourhood needs, to put them into those public sector contracts as a social value ask, and to get those things back from our providers in different ways. So if you're not specifying, if your local authority, if your public sector body near you is not specifying what they want social value to achieve, then from speaking with lots of businesses, best case scenario, that business is coming up with its own ideas. And I can tell you that largely involves looking on Google for what they think neighbourhoods need. Worst case scenario, that provider's social value is not even being realised at all. And you're missing an absolutely huge opportunity to generate resources for community sector. And the opportunity is absolutely huge. So in 23-24, nationally, they spent 341 billion on public sector contracts. Now, on average, a social value would equate to about 20% of a contract value. So if you've got a £1 million contract, you can expect to receive about £200,000 back in social value. So if you think about that 341 billion number, if you get even 1% of that back to support health creation, we're talking about £3 billion in resources to support the work we've been talking about today. And don't misunderstand me, that's not it all in cash, okay? We haven't suddenly won the lottery. But that is about resources we can use for health creation. So in this time, when there's so much pressure and there's so much demand and we've got this appetite for change in this room, how could we actually use social value, this act, as a strategic opportunity to support more community-led initiatives, okay? So this is where we're going to the workshop-y style bit for you. So my question to you, if you had £3 billion for health creation, what would you use it to do? And that's where it comes down to being able to articulate that. So we're going to take, I've said 5, but we'll see how long we've got, Merron, hey? Let's take a moment to pause, either on your own or with your neighbour. Try and think about a statement that describes a priority you would like social value coming from your public sector contracts in your area to address. And I've put a kind of draft statement there. I can't actually read that on that screen, so I hope you can see it from where you are. I've put a draft statement there. I would like providers to contribute to the issue of, you can write what matters to you, and then try and write some statements about how you think you'd like them to do that. So it's just to get you thinking. Okay, so over to you. And if you are a public sector person and you've got some contracts coming up, do think about where you can start to ask this. If you're not a public sector person, we'll come on to that in a moment. So over to you. Take a few minutes, just have a think, try and fill in that statement. If I had £3 billion in social value, I'd like to use it to achieve these things. Okay, I've just got one slide up there. Yes.
I'm dying to put my £3 billion answer into that one.
Okay, so I hope that's given you a micro amount of time to start thinking about that. Let's come back to that together and push on. So we won't be talking about the ideas you shared, but please do use the Menti. I've put it here. You can log on to that. And please do share what you've been thinking of so we can add that and see what everyone's thinking about. And today was only a micro experience. It's worth going away yourself, spending more time on that, reflecting on that. And I've put some other prompts on the screen there you may want to consider as you go on. And just to finish, sorry, Merron, just to finish, it's worth just saying, as you're reflecting, please do think about who in your neighbourhood is actually creating health. So which organisations do we want to support with this social value opportunity? What support do they actually need? And within that, how you can think about your budget in more palatable, bite-sized chunks. So if you're thinking about what you want, saying I need 100K is probably not going to be responded to. So we need to be insightful. And this is good to prepare not only to make use of social value with your local authority, with your public sector organisations, but it's also to prepare yourself for different types of funding streams in the future. So that's all from me. If anybody wants to follow up, you can contact me there. We can have a conversation about it. Over to you, Merron.
Thank you. Yeah. And that deserves a round of applause as well. So huge, thank you. Can I just do, just before coming to Alex, really quickly, who here has not heard of social value before? Okay, a couple of people, 3 people. So there are some people who haven't heard of social value before. So who didn't really know what it means? You've heard of it, but you didn't really know what the opportunity was. Hands up. Oh, so most of you did know what the opportunity was then? Okay, well, that's great. Right, in that case, I'm going to come to Alex now. Alex was a director of the Health Creation Alliance for many years and is sort of finding his way back towards us, and we're delighted that he's coming to respond to what he's heard today. Thank you.
Thank you, Merron. First of all, hope everybody's having a good day and enjoying it. Wow, where to begin? There's been so much spoke about today. So I'm going to look at sort of communities and what people think of communities, I suppose, first, as that's mainly my background. So to me, communities starts at home. So, for example, if you're not well, who do you reach out to and talk to first? Your family, parents, friends. So there's the first step to community. If you can build on that and start building those connections between your family, friends, to people that work in the community, to services, you start to broaden that community and everybody becomes included. So you're not just talking everybody that lives in there, but everybody that works as well. And that's the type of relationships that I think are the most important for health creation. On the commissioning side, what I feel commissioning is putting the resources to where it matters most. So every community is completely different. So having a standard definition of what commissioning is won't work properly because it needs to be fluid. It needs to be able to sort of fit around whatever community you go into. So being Scottish, sometimes I work in Scottish, so you're Scottish as well. You'll know in our communities there's a lot of banter, an awful lot of banter, which you couldn't take that somewhere else and expect it to work because it wouldn't. And that's what commissioning has to be. It has to be something that looks at the area, looks at the people, and finds what works best for that. So again, looking into communities, community groups, you've got lots of community groups that are very well established. There was one I was reading a few weeks back. It's done a social return on investment. For every £1 spent, it's saving £40. Which, if you think that over a large scale or a lot of money, that's a lot of money that's getting saved by services. Community groups sometimes get overlooked on just how much of an impact they have on services and communities in general. And I think I'll stop there. Thank you all.
Thank you. Thank you, Alex. That's wonderful and great to hear. Some reflections, not just on commissioning, but also on the sort of families and friends and networks being the first port of call. I think that's a really quite important part of health creation. It's not just about the wider community, it's about the people closest to us often. Okay, so we've got time for some questions. I've got some thoughts as well, but I'm going to go to yourselves first and see if we have. So I don't know. Shall I? Yeah. Would that be a possibility? Thank you, Claire. That's brilliant. Thank you, Claire.
It's kind of not a question, it was just a comment. You know, you asked us to do that little exercise, and we had a really great discussion on the table. And I think, hopefully, just to summarise it quickly, the 3 million would be to invest in infrastructure to support community growth, to invest in grassroots work, so to mentor community activists and people, community connectors that naturally grow in communities, because there lies our sustainability of community growth, and training and development. So we really lack in the voluntary community sector. We lack development workers, and we lack those people that can work on the ground with people to support and mentor them. So a good training programme, an accredited training programme for working with universities for community development.
Anyone else with any points they'd like to make, or questions, or? No?
Oh. I've been usurped.
There's someone over here, I think. Jeanette.
I hope this doesn't sound like a stupid question, but how can we measure social impact? Because we've got a project locally and we want to be able to measure. Is there any sort of measurement?
Can you speak up a bit?
How can we measure social impact?
How can you measure social impact? Alex, yeah.
There's a lot of services that do an SROI, which is a social return on investment. So they can come into your community, they'll ask a lot of questions of people that use your services, etc. They'll go away and calculate based on, so the people that come to you, maybe they go to the doctors less or visit hospitals less, things like that. Then they go away and they work out the social return on investment to work out for how much every pound that is spent in your organisation to how much it will actually save services and that further down the line. I don't know if that helps.
Yeah.
They're usually called social return on investment. There's a few websites that do them, and a few, I think, universities do them as well.
Perfect. Thank you so much. Thank you.
Sorry, Jeanette, just to add to that, Alex is absolutely right that there's the kind of frameworks. I think my experience of working with the voluntary sector, it's worth being really clear what you're actually trying to achieve, because you can have hundreds and hundreds of metrics, and if you're never going to look at them, all you're doing is adding burden. So I think rather than thinking about how we can measure social impact, if you think about the outcome you want, this is about ending homelessness, or this is about people feeling happier, or whatever it is, and tailor your metrics to that. And there's lots of frameworks out there, so I can send you some if you'd like, be interested in those, and you can select the ones that matter most to you, but trying to keep it concise is probably helpful.
Thank you so much. I was just thinking of sort of the impact measuring, because what we're doing is slightly different, isn't it? So we're just looking at how, if there's anything extended, we can measure the impact of the social value, because it's like a ripple effect, isn't it? But thank you. That's it.
Yeah, I was just going to say that whenever you measure impact, it's really important to define exactly what it is you're looking to change, because if you don't define that really well at the beginning of the project, then coming to measure it afterwards is quite tricky. So it's the same even with any form of scientific research program. You've just got to set out exactly what your aim is at the end before you start, really.
Just to say, Merron, we've got someone there, someone here, and someone over there.
Perfect, thank you. So, Rachel.
Thank you, Merron. Just a quick comment and a question linked to what you were saying, Rebecca, and then the question that came from the audience about the ideas. So I work at Peabody Community Foundation, and we have real focus on social value from our contractors that bid for the work to develop homes. Something that we find really interesting is a lot of projects that are really sellable to social value partners are the things that they can, sorry to sound cynical, but you can get the photo ops and the, so I think something like the van conversation we had earlier about the colleagues in Lancashire, I think, just there's potential to unlock some of these kind of bureaucratic issues around the inertia of systems and local authority funding and all that stuff. You can maybe get around that through social value, maybe? Is that something that you've seen in your work? Yeah.
Yeah, absolutely. I think, so it's really interesting, particularly working with communities and some of the things they do that are kind of discretionary health type services. Absolutely, there's ways to provide different things by using social value as a model. And I think you're right that often for businesses, they like the kudos of it, and rightly so. It makes them a good employer. It makes them, it's something for them to be proud of. But I think actually using that as an opportunity to engage with them. People who work for businesses are people like the rest of us, and they've all got a personal story, and they've all know somebody in their family who would probably benefit from what you're providing and things. So sometimes I think it is about creating those relationships we've talked about today, but not just about photos, but about creating a kind of emotional attachment, as somebody said earlier, to what you're trying to achieve. And then that does change the whole relationship, and you can do different things that you couldn't do if you were trying to mobilise a health service, for example, to donate the money to it. So it creates a freedom, and particularly that freedom for communities to do new things, different things. Does that answer your question?
Thank you. So somewhere around here, there, thank you.
Hi, my name is Priyanka Gandhi. I'm from One Vision. My question is, how can funders and policy makers recognize the economic value of social capital built by local groups, especially those working in faith or minority communities?
Who would like to have a go at that?
I mean, I think it's about what we've already been talking about is showing that impact value that you're having. Because the moment you can show the impact that you're having, you can generate some interest in further capital investment into what you're doing. But the trouble is at our grassroots level, you know, that as we are working in primary care, it is actually very difficult for us to get the ICB, our biggest funder is the ICB, to get them to look at what we're doing and to invest in that social value, even though we've got the stats to demonstrate it. And I don't really know how much more we can do other than produce those kinds of stats with our proms and all the rest of it, with our patient responses. So I struggle to answer that question, and I'm hoping that you might be able to.
As I said, we'll pass it along, and by the time you'll have the solution. I mean, funders and policymakers, it's really interesting because for me, I think there's a massive culture change there about recognising social capital in communities. So this is not going to be a sudden kind of, oh, we did this, and then they decided actually it was worth recognising what's going on in the community. And I think you do see lots of people, and we've seen some of them here today, from kind of funder and policy-making roles who are really passionate about what the neighbourhoods and what the communities can do. But I think we need to go on that culture change journey. And there is huge skills demand actually in health and care, which I think creates an opportunity perhaps to recognise the social capital you can get through neighbourhood groups. And there's something there then about shifting to asset-based approaches. And so that's the culture change I mean. So when funders and policymakers, rather than thinking they have to solve all the problems, which we would consider a deficit-based model, to an asset-based, what tools, what resources have I got to do this? And actually my social capital is one. So that kind of cultural understanding shift, I think, for funders and policymakers is really important. Now, I've seen glimpses of that starting, and that's why I'm passionate about social value, because, as I said, I think it creates a low-risk opportunity to start investing in some of that social capital and really starting to build up what it can do and have it recognised as part of the system. There's other ways as well, but for me, that's the journey, that cultural change towards an asset-based approach. Does that help? Did you want to say anything?
I mean, and the other option, they're great answers and really good ways, but it's also possibly increase chances of gaining funding. Sometimes it's about looking for partnerships. So like-minded organisations or groups where you can collaborate to do something bigger and stronger with more impact, which can sometimes gain extra attention for hopefully securing some extra funding.
Merron, it's lovely to have a teammate helping me.
There's one more question over here, and then I'm going to finish with a few comments and wrap up, I think, because we've got 5 minutes left. So we've got one question here. Did you say there's one here as well?
There is one here if we've got time.
Okay, we'll go over here. Adrian.
Thank you, Merron. This started off as a response to the impact question, so that was a while ago now, but I'll try and convert it into the current conversation. I suppose if this workshop is kind of in the context of commissioning as well, then I'm interested about the role of impact measurement within a more health-creating commissioning landscape. And in the project work that we've done at, you may or may not have been in our workshop this morning at Manchester Settlement, it's about really taking all the health creation principles and applying those in a 360-degree way in terms of our own practice and encouraging those that wrap around us to have health creating practices in all of their work with us, including that commissioning. How that relates to the question around impact is that if the debate around impact measurement is owned by ourselves, we've got the freedom to create that and design that ourselves with our own service users. That's one thing. If that's influenced by the people that might be funding us to do something, and they are giving us a set of objectives and a set of indicators where we need to be framing our impact, then it's very much about trying to push back, and if those commissioners are truly interested in health creating approaches, then it's not just taking what's given to us in terms of expectations around impact measurement, but actually softening the edges of that and opening up the opportunities for identification of unintended impact and ripple effect and all these kind of things, I think are really important in terms of how we measure impact rather than just following an agenda that follows the power.
I think there is one more question, but I just want to bounce off that first, which is you've sort of gone back to the health creation framework, and I think one of the points that someone raised this morning is if we're going to do this well, we need to understand what it is that creates community agency. And I think that's kind of at the heart of this, really. It's not just investing in communities, it's investing in community agency. And understanding the difference there is part of what will help us to deliver this really well. I think when it comes to commissioning, I heard Cordell give sort of 3 elements this morning: strategic planning, procurement, monitoring and evaluation. But then I've heard others describe it as market shaping, others as understanding the needs of the community so that we can create the right responses. That was Alex just now. I think people have an unclear idea of what commissioning really is, and there's no, I've never sort of thought about, I suppose we've got world-class commissioning, haven't we, as a term? What does world-class commissioning look like? But I do wonder whether there's a lot of fudge goes on, and do we really think in terms of decommissioning things that aren't creating the value? There's a big one. Okay, right there, the massive elephant in the room that we haven't even gone into today in this session. I think there's something about how can we do it really well. And we think that the health creation framework that I showed you earlier is a key part of that. We do have a way of measuring how health creating different things are in terms of the quality of the relationships and the different features of those relationships, and that's what work we've been doing with Manchester Settlement. So we think there's an element here that is important for commissioners to understand in order to get to that point about how to actually create community agency. So I'll leave that there. Do you want another question, or do you want to go to coffee? Hands up who wants another question. And who wants to go to coffee? Right, I think we've got another question. Well done, Enoch.
Thank you. My name is Enoch. I think you have answered many of the questions. And the question I'm going to ask as well, follow up from what Priyanka is asking. I'm still perplexed with CAN, social return on investment framework. how can we measure the preventative impact, particularly with hospital admissions, those faith groups and those communities who particularly work with ethnic minorities? And we have given many times, but they got their own framework and they got their own ideas behind it.
Gosh, so this is about how to measure the return on investment when it comes to hospitals. I don't know if has someone got some. Yeah. Okay.
Time to think, Merron. I think it's really interesting talking about prevention because you can't measure what hasn't happened. So there's no actual way to measure a preventative impact. What we can use is proxies. So there's lots of standardised proxies out there. So one ambulance call out largely costs around this much money. That will vary between regions, of course. So you can use proxies like that to think about it. But part of it is knowing that going to change what we do. And I think actually people pursue this idea of being able to measure prevention potentially as a way to kind of avoid really getting down to the nuts and bolts of what we want to do. And I think actually if what we can do is say, it is good, and we know there's loads of evidence, it is good for people to access green spaces, as an example. Yeah, that is good. So we're going to do that. We're going to pursue that as one thing. And then if we pursue these things, we will start to see hospital admissions coming down. And you can never say a hospital admission is prevented by one thing. It will be prevented by a whole mix of things anyway. But over time, you will start to see those metrics. So I think, for me, measuring prevention is less about cause and effect. I did X, it prevented Y. It's more about, we did A, B, and C. We can see from this it's improving people's quality of life. That's what they're telling us. And over time, we will then see metrics like hospital admissions, for example, going down. And you can start to measure those things, but it will never be cause and effects. You'll never get the preventative this did that you perhaps want.
Thank you. Right. Well, I'm going to finish now. We're 3 minutes over, and quick cup of coffee, a bit of time to have a comfort break, and then we're coming back for a panel, another sort of different sort of a panel session with others later with Durka and some others at 4:10. So just one last round of applause for our panel. Thank you very much to Alex, Rebecca and Mina.